since 1 week. She arrived in the accident and emergency after uncontrolled repeated vomiting. The last vomitus contained the cherry-colored clots. She recently passed black-colored, very offensive stools. She was a known case of common migraine, and she often had to take tablet aspirin in large doses to relieve this pain. She was previously diagnosed a case of the gastroesophageal reflux disease, the rolling hiatus hernia, and she received 2 pints of the blood transfusion before her marriage for the anemia 7 months back. They don't know the cause of the anemia at that time. On examination, the temperature was 98 degree Fahrenheit. Pulse is 122 per minute. It is high volume. It is a bulky pulse. It is a bounding pulse with collapsing in character or nature. The blood pressure in sitting position was 100/76. In standing, after 3 minutes, it is 77/56. Normally, there will be a difference of less than 10. And systolic, and in the diastolic, it is 5 millimeter difference. In normal people, most of the people. 20 millimeter is a significant difference. It indicates the postural drop. What it indicates is another thing, that is the blood which is coming in the vomitus is not the only amount which you see. Actually, there is a hidden blood which is inside the intestines or in the stomach, whatever the part of the GI tract is concerned. There is more blood which is present now. A lot of bleeding occurs. It means a lot of bleeding occurs. Postural drop. And that is why the pulse is high and is high volume and collapsing in nature. That is why. The other systemic examination was unremarkable except the tenderness in the upper central abdomen. There were hepatosplenomegaly of 2 centimeters. The case was referred by the gynecologist to the internal medicine for further evaluation. When she arrived, she had some of the investigation she owned, like hemoglobin 6.5 gram, RBC is 1.9 million per cubic millimeter, which is very, very low. It should be more than 3.5. MCV is 54 centiliter, which is normally 78 to 96. So there is microcytic type of anemia. MCH is 19. Normally it is 24 to 28 in the lab. And MCHC is 27. It is 32 to 36, which is normal. I mean, both MCH and MCHC were below normal. So it is microcytic hypochromic type of anemia. WBC is 8,700, which is normal. Platelets is 1,10,000. It is lower down. It is mild thrombocytopenia. 150 to 350,000 is normal. Because of acute bleeding, the platelets should increase rather than decrease. It means there is something going else in the body. The random blood sugar is 177, sodium is 127, potassium is 3.2, chloride is 90, all are lower down. Bicarbonate is 34, it is alkalosis. It is metabolic alkalosis. Why? Because of the vomitus also contains the hydrochloric acid. Because the hydrogen ion is lost in the vomitus. and if hydrogen is lost, it means that the bicarbonate should raise. The metabolic alkalosis is compensated by respiratory acidosis. So respiratory rate should be acidosis, respiratory acidosis is reduced rather than increased. You have to retain, there should be a retention of carbon dioxide so that the respiratory acidosis will save her. The question is what is the differential diagnosis and how we further investigate what is the most probable cause of the hematemesis and what will be your lines of management. It is a very interesting situation. Now in this case the differential diagnosis is manifold. She was anemic before her marriage. They don't know the type of anemia, why she was anemic. What type of anemia it was at that time, they don't know. The second thing is this, that she has already diagnosed migraine and she has been on the drugs like aspirin, acetyl salicylic acid, which increases the acid production in the stomach, and it can cause acute gastritis, and it could cause the ulcerations in the stomach. It may be the cause, because she was pregnant, and in the early pregnancy there is definitely nausea is there, no doubt. In some ladies the vomiting is also a common feature. Now she developed vomiting repeated, and because of the thrust of the vomiting, physiologically the stomach should contract. There is ulceration in the lower part of the esophagus, tear which is called the Mallory-Weiss syndrome or Mallory-Weiss tears. This may be a differential diagnosis. Now, other diagnosis may be possibly she has got underlying liver disease because of the platelet which is 1,10,000, splenomegaly, hepatosplenomegaly. It's possible there is a latent liver disease in her. So there are a lot of differential diagnoses you can be made. The investigation should be done for these diseases which I have told you, and we will discuss definitely. The probable cause of the hematemesis, in my opinion, in this case, is the Mallory-Weiss tear, rather than the big thing like esophageal varices. Remember, hematemesis is the most warning problem. I have seen 10 to 15% of deaths with one vomitus with blood. So much vomiting is not there. Only one vomitus with blood. The patient was collapsed and she died because of the lot of hemorrhage occurred inside, which was hidden, latent bleeding inside. Everybody definitely is terrifying from this condition, whether the patient or the doctor. Both are. This is a very bad situation for both of them, because the line of management depends upon the etiology. We will discuss later on. But the thing is this, you have to take the history very carefully, because you have to differentiate between hemoptysis with hematemesis. Now this is a chart is in front of you. It says that in the hemoptysis, symptoms is very important relating with the respiratory tract is concerned. For example, bronchi, wheezing, coughing, gurgling noises, preceding by these type of signs. The chances that the blood which is coming out of the mouth is hemoptysis. But if it is preceded by the nausea, accompanied by the retching or water brush or something like that, it is possible. Is more chances of relation with the hematemesis. Now, color and consistency of the expectorated material which is coming out of the mouth, which is bright red, a frothy consistency mixed with the sputum, it is the bleeding is from the respiratory tract. But if it is dark red, cherry colored or brownish, there is a modification occurs actually. The blood is coming out from the lower part of the esophagus or the stomach. There is alteration occur in the blood because of the many products of the stomach and because of the deoxygenation in this area. It is a modified blood. It is altered blood, which is it. So it is coming from the GI tract. The consistency of the material may be mixed with the sputum. Yes, if it is respiratory tract is involved. If there is food particles associated in vomitus, it indicates it is coming from the GI tract. In physical finding, the localized, I already said, there are capitations or bronchi, and there is the digital clubbing, etc., etc. Or there are, loss of or decreased breath sounds, indicative of that the blood which is coming out is from the respiratory tract. If there is a hepatosplenomegaly with abdominal tenderness or ascites, etc., this indicates that it is related with the GI tract. Or there is a tenderness in the epigastrium, very tender, which also indicative of the GI tract. The gold standard to differentiate between hemoptysis and hematemesis is to do the pH of the expectorated blood. If it is alkaline or neutral in nature, it is hemoptysis, otherwise it is acidic. I have seen in my career, when I was in third year, my professor, Khwaja Muinuddin, he was a very famous physician. He himself done with the litmus paper the blood which has come out from the mouth, and it seems that it was coming from the GI tract. He said, no, it should be confirmed. And when he examined the pH on the litmus paper, it was turned to be alkaline. He sat down, see, this is symptom-wise seems to be, it is hematemesis. But the gold standard is definitely of the acidity or alkalinity of the material which is coming out. Will decide. Remember these points which are very important in your life, because if you are doing the post-graduation in England or in US or Canada, now these type of question will be asked as in BCQs or MCQs. The major causes of bleeding from the GI tract is concerned, basically. From the peptic ulcer in the most of the part of the world, peptic ulcer disease, 33.9%. Esophagogastric varices. In our country, the commonest cause of the hematemesis is esophageal varices, not peptic ulcer disease. Erosive esophagitis, malariostea, gastric erosions, tumor from the stomach or the esophagus, esophageal ulcerations. I said it can occur from the GER, gastroesophageal reflux disease, that is, the esophageal ulcers can be produced, and the portal gastropathy. It is just like esophageal varices, the same thing. If the stomach is involved with the varices, it is portal gastropathy. If the junction is involved, it is called the esophageal varices. There are other causes like coagulopathies, etc., which are very less than 2.7%, least chances. In our country, the most common cause is the esophageal varices, followed by the peptic ulcerations, followed by the drug-induced gastritis, drugs, NSAIDs, etc. These are the main causes of hematemesis in our country. The peptic ulcer disease occurs, in the stomach, and mostly it is near the greater curvature, rather in the lesser curvature. It may be in the trunk of the stomach, the body of the stomach. It may be in the fundus, or it may be near the pylorus. It is not the subject of discussion. I said this is the cause, because the peptic ulcer disease is so common nowadays. Because of your habits, the people do not follow the lifestyle modifications. Esophageal varices, this is the cause of this cirrhosis. If you see the varices in the upper GI endoscopy, it means that the patient has developed the cirrhosis, and you have to manage this condition urgently. Otherwise, very severe bleeding can cause death at any time, and the patient can develop another important complication, and that is the hepatic encephalopathy. The drug-induced, as I already said, the people are taking the aspirin, the indomethacin, brufen, ibuprofen, mefenamic acid, diclofenac sodium, naproxen, or COX-2 inhibitors in large doses. They can all cause the gastritis, and gastritis will lead to the ulcerations. That is called erosive type of gastritis. And the blood accumulate in the stomach, and you feel nausea, and then vomiting occurs with the blood. It is altered blood, I said already. Just not like the blood when you sacrifice the animal, the blood is coming out, it is very, very red. It is bright red. It is not bright red. It is coffee colored or cherry colored. It is altered blood. Carcinoma of the stomach occurs usually in the lesser curvature, and it is adenocarcinoma most of the cases. And in the cases, the obstructive element is more than the ulcerative element, and there ulcerations occurs, there will be chances of vomiting with blood. Now the characteristic of the bleeding, the hematemesis, It is a coffee ground versus bright red color. I already said that. It is altered blood. The terminology which we are using here. I have explained the difference between the hematemesis and hemoptysis also. Another condition which is seen is melena. Now melena is a dark terry colored stools, black usually, very very foul smelling, pungent smelling, and it's just like the stool which is coming out is more in quantity and without formation. It's just like a gobar of the buffalo. It is called melena. There are 4 characteristic features of this condition, melena. If you want to produce a melena in a patient, there should be at least 150 ml of the 150 to 300 ml blood should be lost to produce one dark black stool. It may be from the small intestine or the proximal colon if it's slow bleeding. Usually it is coming from the stomach. Another terminology we use is hematochezia. It is bright red color. It is not altered blood. It's usually coming from the lower part of the GI tract. And it should be more than 300 ml. 300 ml, 500 ml, 700 ml. Usually it is in larger quantity of the blood. And can be seen with the massive, if there are massive bleeding in the small intestine or the massive bleeding in the upper GI bleeding because of the coagulopathy, the hematochezia can occur also because of the rapid movement of the intestine, because of the abdominal hurry. The hematochezia can occur from the upper GI bleeding. In those conditions where there is coagulopathy or there is a massive type of ulcerations. Another condition is occult blood. Now, occult blood occurs when there is bleeding from the upper GI tract, and it is very small in amount. It is less than 150 ml or less than 100 ml. Even 50 ml to 10 ml can be detected, and in stool seems normal. There is no color change, but you go for the guanic test. The guanic test will tell you there is a blood which is oozing from some part of the upper part of the GI tract. You have to do the examination, vitals, abdominal examination. Liver should be palpable. The liver span and spleen examinations, and the dullness examination of the abdomen to see the ascites. There may be signs of perforation if there is ulceration and it is perforated. You do the rectal examination to confirm that bleeding, what type of bleeding it is. If it is a bright red in color, it may be coming from the very, very near to the anal canal. Nasogastric lavage, it is not required, but it can be helpful to differentiate between the upper and the lower GI bleeding. Upper GI bleeding or the lower GI bleeding, you can do the nasogastric lavage. Because nasogastric tube intubation is a procedure which the patient does not like. Remember this thing. He hates the nasogastric tube intubation. Labs should be done Of course, I already said CBC, all the tests, PT, APTT, liver function test, albumin, globulin ratios, blood urea, nitrogen, creatinine, these all should be done. Ultrasound of the abdomen, upper GI endoscopy, which is the gold standard in this case also, to see the site of the bleeding, and diagnosis will become very easy then afterwards. There is assessment of the severity of bleeding, which is called the Rockall score. The Rockall score is the score which will tell you the triage. If there is a triage, it means that this is the patient of ICU or HDU. If the age is less than 60, score is 0. If it is 1, score 60 to 79, score 2 is more than 80, score 3 is more than that. Now the shock is none in 0 score. If the patient is without pulse, if the pulse is 100, more than 100, score 1. Systolic blood pressure is less than 100, it is score 2, and it is lesser than that, then it is pulseless, absolutely it is. Again it is score 3. The major comorbidity in this case is none, 0 score. There is no comorbidity in score 1 also, and in score 2 the cardiac failure is there, is ischemic heart disease, similar major comorbidity, or diabetes mellitus can cause some problems related with the stomach also. In score 3, renal failure or the liver failure or metastatic cancer has been diagnosed previously. The evidence of bleeding is none in score 0 and in score 1 also. The evidence of bleeding is blood is adherent and clot and spotting vessel. You see under the endoscopy, therefore it is score 2 if there is a spotting type of the vessel and oozing blood. More than that is 3. The diagnosis you made was score 0 is malarial. In her case, which I have discussed, it is malarial. So she has got 0 score. But no major lesions and no stigmata of the recent bleed. Otherwise, if she has Peptic ulcer disease, then it is score 1. Other non-malignant gastrointestinal diagnosis. But if she has the upper gastrointestinal tract malignancy type of thing, it is score 2. Less than score 3 carries good prognosis. If there is a score of 8, carries the high risk of mortality. So, if there is the triage, I say, the score is more than 3, 4, it is a triage. Triage means that you have to help this patient from the death by admitting this patient in the ICU or HDU. Now, emergency management is the management of the shock, remember. Triage, hemodynamic instability or active bleeding, going to the ICU or HDU. Shock is managed first. And immediately you have to consult the GI consultant who will do the endoscopy. Before he will arrive, you put the 2 large bore IV lines, 16 gauge or larger than that, so that the blood transfusion can be done. If the blood is not available, then plasma can be given. You have to manage the shock first, remember, in your life. If the shock is managed, then you go further. And the bolus infusion of the acetonic crystallite, that is, as I said, the serum, plasma, or related substances can be, colloids can be used. So the transfusion is very important part it is played. After cross-matching, the whole blood should be given. If there is coagulopathy, the FFP will be given. If there is the thrombocytopenia, the platelets concentrate will be given, etc., etc. So trending here is the highly important in this case that you have to manage this case within 6 hours. Hour to hour is important. And the patient will become NPO until the diagnosis and the bleeding stops for at least 8 hours. The management, other than that, we use the intravenous PPI can be given. Omeprazole can be given very easily. Esomeprazole, it can be given. Protonoctine, 80 milligram intravenous bolus. Then the proton pump inhibitors had got a very good role in the gastric ulcerations or stress ulcerations even. You have to avoid the NSAIDs, acetylsalicylic acids or anticoagulants, antiplatelets. I have seen one of my friend who had been on the clopidogrel. He had vomited. He had vomited twice the blood. When he was posted in the medical college in Mirpur Khas, he asked me what is happening to me. I said that because of the clopidogrel you are taking, probably it has caused this problem, and there is a bleeding because you are a smoker, and there is gastritis. It will lead more bleeding in the stomach, and there is hematemesis you had. So it was confirmed then afterwards that actually the clopidogrel was the culprit. The suspected urethral bleeding because of the cirrhosis. If the endoscopy and the endoscopy, or without endoscopy even, the other measure you can do is the somatostatin analogs, octreotide 50 microgram intravenous bolus, then 50 microgram per hour infusion. It will help in reduction of the portal hypertension. And they don't know how the bleeding stops. They don't know exactly, but most probably because of the reduction of the portal pressure, the bleeding stops. Before that, somebody also tried the vasopressin intravenously. In our wards, we have used. Antibiotics can be used if there is the element of infection, and you have washed that, or you have proved that there is something going wrong in the stomach which is infective in nature, which is causing the ulcerations. Assessment and resuscitation. Now this is a chart in front of you. That it is a triac. You have to admit this patient if it is an unstable patient. It is active bleeding. If there is no triage, the patient will be admitted after the management of the stopping of the bleeding in the wards. Medication we use already mentioned out. That is, we use omeprazole, we go somatostatin, etc., octreotide and antibiotics, and the blood transfusions. we have to consult the GI consultant because of the endoscopy. He may tie the esophageal varices very easily, or bending of the esophageal varices can be done. The patient should be NPO for 8 hours at least after the procedure to 12 hours. In some cases it will be even 24 hours after the bleeding stops. The take-home points for student is that obtain a good history. History is very important. Triage, if it is triage, then go to the ICU versus wards. If there is no triage, then go to the wards after the stopping of the bleeding. Contact the GI consultant immediately. Examination and diagnostic data should be collected, and emergent management should be done. Especially I say that the shock should be managed. And if there is a underlying cirrhosis of the liver, manage the complications of the cirrhosis with variceal bleeding. Add somatostatin analog and the empiric antibiotics to reduce the chances of hepatoencephalopathy. So this is the discussion which